Hello, this is Mirrakhimov. I'm one of the cardiac anesthesiologists at the University of Kentucky and also a PACU rotation director for our program. Today we'll start talking about a 12-lead ECG, a PACU primer, part 1. This will be a two-part series. And here's my email if you have any questions or comments about the lecture. I hope that this lecture series will help you better understand 12-lead ECG and help you diagnose time-sensitive arrhythmias and EKG changes in a timely manner. Let's keep going. I have nothing to disclose in regards to this presentation. So what is our agenda for today? First, we'll review the cardiac conduction system, followed by a discussion of the differences between the cardiac myocyte and conduction action potential. We will learn one of the ways how to systematically approach 12-lead EKG interpretation, and also touch base on the findings of a paced rhythm on a 12-lead EKG. Again, disclaimer. The clinical case scenarios which are presented here are only for educational purposes. Any resemblance to real patients or medical situations is purely coincidental. Do not use this information as a substitute for professional medical advice, diagnosis, or treatment, and always consult with a qualified healthcare provider regarding your specific medical concerns. It is impossible for us to fully understand 12-lead EKG without a basic idea about the conduction system. So let's start with the main one, which is a sinus node. The sinus node is located at the junction of crista terminalis and superior vena cava. When we are placing central lines from the superior vena cava perspective, such as for example internal jugular vein or subclavian vein, the guide wire can sometimes stimulate this area and cause arrhythmias. Sinus node is supplied by RCA in about 55% of patients and by left circumflex coronary artery in about 45% of patients. The atrial internodal tracts supply and connect the right atrium to the left atrium and help to spread the cardiac impulse. Next major one is AV node or atrioventricular node. One of the functions of the AV node is to delay the cardiac impulse generated by the sinus node by about 0.09 seconds. This is quite important. And why is it important? It gives some extra time for atria to empty into the ventricle before the ventricular systole. The AV node is located close to the septal leaflet of the tricuspid valve, and that is one of the reasons why patients who undergo tricuspid valve surgery have a high risk of AV node dysfunction post-op. AV node is supplied by the RCA in about 90% of the patients, and the rest is supplied by the circumflex. His bundle is next, and is divided into left anterior fascicle, which is typically supplied by the LAD, and left posterior fascicle, which is typically supplied by the PDA, or posterior descending artery. In the vast majority of patients, the posterior descending artery gets its stem from the RCA. And the right bundle fascicle is supplied typically by the LAD. And here on this pictorial, you see a nuanced representation of a conduction system. Again, pay attention to the close proximity of the tricuspid valve and aortic valve to the atrioventricular node and the proximal part of the His bundle, explaining why those valvular surgeries carry a high risk of conduction abnormalities in the postoperative period. Here we'll talk about some similarities and differences between the action potential of a pacemaker cell and a cardiac myocyte cell. Here on the right part of the screen, you see the action potential of a cardiac myocyte. It has different phases, and different ions are responsible for each phase. It is very important for us to have an idea about this, since it's a highly tested subject. So take a look and review the ions and electrolytes, which are important in different phases of cardiac myocyte action potential. On the left part of the screen, you see an action potential of a pacemaker cell in the heart. And again, it appears quite different from the cardiac myocyte action potential. Again, please take a look and review what electrolytes and ions are responsible for each phase. Take an extra second and compare the two. Again, this is quite testable subject for our American Board of Anesthesiology exams. So let's take a look at this 12-lead ECG. This is a normal 12-lead ECG, and we'll talk about some basic things here. The standard recording speed for a 12-lead ECG is 25 millimeters per second. It is typically reported somewhere on the ECG paper, and in this particular one, it's reported in the left lower corner. If you notice, the ECG paper contains large boxes and small boxes. With a standard recording speed of 25 millimeters per second, one small box on the horizontal axis equals 0.04 seconds. Again, one small box equals 0.04 seconds. Large box contains 5 small boxes, and one large box equals 0.2 seconds on the horizontal axis. And again, a large box equals to 0.2 seconds on the horizontal axis. On the vertical axis, one small box equals 0.1 millivolts or MV, and one large box on the vertical axis equals to 0.5 MV. Sometimes the ECG is recorded at a different speed, and again, this will lead to different intervals. Second most common recording speed of an ECG is 50 millimeters per second. Remember that if this is a recording speed, all time intervals will appear twice as long as compared to recording at 25 millimeters per second. Again, when you have a recording speed of 50 millimeters per second, that all time intervals will appear twice as long compared to a standard recording of 25 millimeters per second. On this slide, we see the relationship between different phases of the cardiac cycle and 12-lead ECG. Early part of systole, which is isovolemic contraction, typically corresponds to the peak of the R wave, followed by ejection phase, and the systole typically ends with the end of the T wave. The next cardiac phase, which is diastole, typically consists of 4 different substages, such as isovolemic relaxation, rapid inflow or early filling, diastasis, and atrial systole. Atrial systole typically follows the P wave on the 12-lead ECG. So the diastole in the 12-lead ECG typically starts after the end of the T wave and ends just around the middle portion of the R wave. It's when the systole begins. Again, take an extra second here to review and understand the timing of cardiac events and the relationship to ECG. When reviewing an ECG, it is important to have a systematic approach, which is somewhat similar to a systematic approach of an anesthesia machine check before your first case, and also, for example, to a systematic approach how you do certain procedures. One way, which is presented here, includes cardiac rhythm, heart rate, axis, QRS interval, ST segment, QT interval, and an overall impression. It is very important to review the new 12-lead EKG to the previous one to assess for any dynamic changes. We'll go through our systematic approach to 12-lead EKG. We'll start with the rhythm. And the first question is, does the patient have a P wave? A normal sinus P wave will be positive in limb leads such as 1, 2, and AVF, as well as leads V4 and V6. And again, sinus P wave will be positive in lead 1, 2, AVF, and V4 to V6, and a negative P wave in lead AVR. These are the features of a sinus P wave. It should last less than 0.12 seconds, and the amplitude should be less than 0.25 millivolts. 12-lead EKG can help us diagnose atrial enlargement. However, it is important for us to remember that 12-lead EKG is far from being sensitive for that problem. Left atrial enlargement will have P wave duration of more than 0.12 seconds, and will also have a negative phase of P wave in lead V1, less than of at least 0.04 seconds or more. Right atrial enlargement, or P pulmonale, will have amplitude of the P wave more than 2.5 millimeters in lead 2, and an amplitude of P wave more than 1.5 millimeters in the right precordial leads, such as V1 and V2. Classically, left atrial enlargement will be seen in patients who have LV diastolic dysfunction or in patients who have significant mitral stenosis. Patients who have right atrial enlargement, you need to think about the presence of pulmonary disease, such as advanced COPD, presence of pulmonary hypertension, and in extreme cases, advanced left-sided cardiac disease. So how do we get the heart rate? Obviously, the EKG machine can do that for you, but there are different ways you can calculate the number yourself. You can count the number of large boxes between the QRS complexes, and you divide this number into 300. For example, that between two QRS complexes, there are two large boxes. You divide 300 by 2, and you get your heart rate of 150. Another option is to count the time between the QRS complexes and divide this number into 60. Normal heart rate for adults is considered to be 60 to 100. So let's do the question. What is estimated maximal heart rate for a 45-year-old male? And the formula is 220 minus age in years equals 175. Let's talk about QRS axis. Axis can help you sometimes to point towards a possible underlying diagnosis. Normal axis is present when the QRS is positive in leads 1 and 2. Left axis deviation is present when the QRS is positive in lead 1 and negative in lead 2. Certain EKG pathologies can give you left axis deviation, such as, for example, inferior myocardial infarction, paced rhythm, Wolff-Parkinson-White syndrome or WPW, left bundle branch block. Right axis deviation is present when the QRS is positive in lead AVF and negative in lead 1. Certain pathologies can give you right axis deviation in the EKG. For example, right ventricular hypertrophy, lateral myocardial infarction, hyperkalemia, WPW, and sodium channel blocker toxicity. It is also important that acute right ventricular strain can give you a new onset right axis deviation. And when the QRS is negative in both leads 1 and AVF, it is called an extreme axis deviation. So what conditions are associated with extreme axis deviation? Obviously, misplaced EKG leads. When the misplaced EKG leads, probability is ruled out. Severe right ventricular hypertrophy, ventricular tachycardia, and ventricular ectopy are associated with extreme axis deviation. Let's take a look at a few examples of axis. Let's take a look at this 12-lead EKG. So let's compare lead 1 to lead 2. Lead 1 QRS is positive, whereas lead 2 QRS is negative, making it a left axis deviation. Let's take a look at another example. Here, let's take a look at leads 1 and AVF. QRS in those leads is negative, making it an extreme axis deviation. And the last one. And let's take a look at the last one again. QRS is negative in lead 1 and positive in lead AVF, making it right axis deviation. Let's discuss PR interval. Normal PR interval should be less than 0.2 seconds. When it's more than 0.2 seconds, it is called a first degree AV block. On the right part of the slide, you see the proper way to measure the PR interval. Let's talk about the QRS complex. QRS complex consists of 3 waves, such as Q, R, and S. It is important to note that some patients don't have all those waves present. For example, R wave can be absent, making it a QS complex, or for example, Q wave can be absent and making it RS pattern. Q waves are pathological if present in leads V2 and V3, if they last more than 0.04 seconds, or if the amplitude is more than 0.2 millivolts. Normal QRS duration should be less than 0.1 seconds, and normally the R wave should increase in its amplitude from right precordial leads to the left precordial leads, or from V1 to V6. So let's keep talking about the QRS complex. You may have heard the term poor R wave progression, but what does it mean? It means that the R wave in the lead V3 is less than 3 millimeters. What is the significance of that? It can be seen in normal patients or be due to lead misplacement error. Some pathological findings which can present with that include anterior myocardial infarction, right ventricular, and left ventricular hypertrophy. Let's talk about right bottom branch block. QRS will be prolonged of more than 0.12 seconds. The QRS morphology in the right precordial leads can vary. And S wave tends to be greater in duration than the R wave, or longer than 0.04 seconds in lead 1 and V6. What about the etiology of right bottom branch block? Think about structural heart disease, such as coronary ischemia, cor pulmonale, or respiratory disease causing right-sided heart strain, iatrogenic, such as during Swan catheter replacement, TAVR-related or transcatheter aortic valve implantation procedures, alcohol septal ablation, for example, for patients with hypertrophic cardiomyopathy, and hyperkalemia. On the right part of the screen, you see an EKG of a patient who has right bottom branch block pattern. Take a look at the right precordial leads, such as V1, V2, and V3. Here you have an RSR pattern in the right precordial leads. Certain conditions can mimic the right bottom branch block. Take a look at this EKGs, type A and type B EKGs, present on the right side of the screen. These EKGs are representative of what's so-called Brugada syndrome, which is a channelopathy problem. Type 1, which is present in the part A, has what's called cold ST segment elevation with inverted T waves, as you can see in EKG labeled A. And type 2 has what's so-called a saddleback ST segment, which is present in the EKG labeled as B. Let's talk briefly about left bottom branch block now. Like in right bottom branch block, the QRS will be prolonged, or more than 0.12 seconds. You have a discordant ST segment changes in relation to the QRS. What do I mean by discordant? For example, if the QRS is positive, then the ST segment will be negative, and vice versa. Quite often these patients have a broad, notched R wave in leads 1, AVL, and V5 and V6. So what about the etiology of the left bottom branch block? Quite similarly to right bottom branch block, many of these patients will have some sort of a structural heart disease, such as, for example, coronary disease, cardiomyopathy, and infective endocarditis. Let's keep talking about left bottom branch block. An old teaching was that if you see a left bottom branch block on an EKG, you think about acute myocardial ischemia. Obviously, this is not always the case, because it's important to assess your patient for any symptoms and review their previous EKGs if possible. Another teaching was that you cannot really diagnose a new ischemia in a patient who has pre-existing left bottom branch block pattern. For example, here, this is a nice representation of a left bottom branch block pattern. Again, pay attention to positive QRS in the left precordial leads, such as V5 and V6, and negative QRS in the right precordial leads, such as V1, V2, and V3. Pay attention to the discordant ST segment changes. For example, ST segment elevation when the QRS is negative in the right precordial leads, and ST segment depression in the positive QRS in the left precordial leads, which is a typical finding of a left bottom branch block. So now compare the second EKG on the right top screen to the EKG on the left top screen. See if there is EKGs are different. Remember we talked about discordance. Again, negative QRS, ST segment elevation, positive QRS, ST segment depression. But pay attention to lead V5 and V6. There is a concordant changes here, and what I mean by that is positive QRS in V5 and V6, and there's a ST segment elevation. And again, it is of note much more difficult to diagnose acute ischemia in a patient with pre-existing left bottom branch block pattern, but it's not impossible, as Garbosa criteria can be helpful in this manner. Also, in patients who have paced rhythm, it can be helpful to diagnose ischemia. We already discussed concordance in the presence of ischemia, or profound discordant changes, such as, for example, ST segment elevation more than 5 millimeters, can also be potential sign of cardiac ischemia. So let's talk about left anterior fascicular block. Again, think about structural heart disease, such as coronary disease, long-standing hypertension, and aortic valve disease. Sometimes patients who have sclerodegenerative changes in the conduction system can also develop left anterior fascicular block. So how does it present on a 12-lead EKG? First, left axis deviation, QR pattern in lead AVL, RS pattern in lead 2, 3, and AVF, which are also known as inferior leads, and the QRS will not be prolonged, or less than 0.12 seconds. Left posterior fascicular block next. The etiology is quite similar to the left anterior fascicular block. So how does it present on a 12-lead EKG? In comparison to the left anterior fascicular block, the right axis deviation will be present. You'll often see RS pattern in lead 1 and AVL, QR pattern in leads 3 and AVF, and like in left anterior fascicular block, QRS will be less than 0.12 seconds. Let's talk about RVH, or right ventricular hypertrophy. The etiology is typically pulmonary hypertension and congenital heart disease, such as pulmonary stenosis. Some other additional etiologies should be considered, such as, for example, advanced lung disease, such as end-stage COPD, or some sort of interstitial lung disease. The differential diagnoses include right bottom branch block, posterior wall myocardial infarction, hypertrophic obstructive cardiomyopathy or HOCM, WPW or Wolff-Parkinson-White syndrome, and a normal variant. Again, EKG is not the most sensitive test to diagnose RVH. So how does it present on a 12-lead EKG? First, you have right axis deviation, lead V1. R wave will be tall or more than 6 millimeters. R wave in lead V1 plus S wave in lead V5 or V6 together will be more than 10.5 millimeters. The RS ratio in V1 will be more than 1, and SR ratio in the lead V6 will be more than 1. Let's take a look at this 12-lead EKG on the right part of the screen. You see that the QRS is positive in AVF and negative in lead 1, making it right axis deviation. Look at the lead V1 with a tall R wave. Next is again lead V1 R wave plus an S wave either in V5 or V6 will be more than 10.5, which is very likely to be present in this patient or in this 12-lead EKG. Again, there is almost no S wave in lead V1, so the ratio of R to S in lead V1 will be more than 1. And again, take a look at the lead V6. It seems that the S wave has a higher amplitude compared to the R wave, and the ratio will likely be more than 1 as well. So let's talk about LVH, or left ventricular hypertrophy. The etiology here is hypertension and aortic stenosis, the conditions which increase left ventricular afterload. Conditions such as hypertrophic cardiomyopathy is also possible. Let's talk about how LVH presents itself on a 12-lead EKG. S wave in lead V1 plus R wave in lead V5 or V6, whichever is taller, will be at least 35 millimeters. R wave in lead V5 or V6 will be more than 26 millimeters. There will be often present some sort of ST segment abnormalities, which are often called nonspecific. Classically in lead 1, AVL, V5, and V6. Let's take a look at this 12-lead EKG on the right part of the slide. Here you can see that in the left precordial leads, such as V5 and V6, there is a very tall R wave. And in the right precordial leads, such as for example in V1, there is a very deep S wave. Obviously you have to calculate it, but it is very likely that the combined amplitude of this wave is at least 35 millimeters. And you also see so-called non-specific ST segment changes, such as T-wave inversion in leads V4, V5, and V6. Let's take a look about hyperkalemia, which was often called a syphilis of electrocardiography or 12-lead EKG. And the reason why some people called it like that was the fact that syphilis, especially in the past, was notoriously known to mimic many other diseases. First of all, let's take a look at this 12-lead ECG, which is present on the right part of the screen. The question is, do you see any P waves? I personally cannot see any P waves, so this is not a sinus rhythm. What about the rate? What seems to be the case, at least 3 big boxes are present between each QRS, so the heart rate is roughly around 100. What about the axis? The QRS complex in limb leads is predominantly negative, so this represents an extreme axis deviation here. Next, is the rhythm regular? It is regularly regular. And also, what about the QRS? The QRS is quite prolonged. So this pattern should make you think about hyperkalemia, especially in the right clinical context. So let's take again a look at some of the EKG findings of hyperkalemia. Peak T waves, short QT interval, loss of P waves, PR prolongation and AV blocks, conduction abnormalities, QRS widening, and sine wave pattern, which is present on this 12-lead EKG. So what about other electrolyte abnormalities and patterns on the 12-lead EKG? Here some of the most common patterns are presented. Please take a second to review this slide. This is sometimes tested on ABA exams. Next, let's talk about ST segment. So the questions to ask include, is there ST segment depression or elevation? Are T waves peaked or inverted? Etiologies of ST segment abnormalities can include benign conditions and also life-threatening conditions, such as, for example, acute myocardial infarction and hyperkalemia, which we briefly discussed before. When assessing whether ST segment is either above or below the baseline, it is important to look at the TP segment, which is between the T wave of one beat or preceding beat and the P wave of the next beat. And again, the TP segment should be used as baseline. So let's talk about different patterns of ST segment depression in coronary arterial disease. It can be either horizontal or downsloping of at least 0.5 millimeters. And again, it should be present at least 2 contiguous leads. What I mean by 2 contiguous leads, such as, for example, lead 1 and AVL, or lead 2 and 3. Again, like we discussed before, whether the ST segment is below or above the baseline should be referenced towards the TP segment. Here we say that the ST segment depression should be measured about 0.08 seconds after the J point, where the J point is the place where the QRS complex ends and the ST segment begins. Let's take a look at this picture. Here you see the downsloping pattern of ST segment depression in several contiguous leads, such as, for example, lead 1 and AVL, and lead V2 and V3. So typically, when you see ST segment depression, it is called non-ST segment elevation MI or non-STEMI. And typically, non-STEMI patients are managed somewhat differently in most circumstances. However, it's important for us to remember that ST segment depression or new ST segment depression can actually represent a STEMI or ST segment elevation myocardial infarction, which is typically representation of acute thrombosis of a major coronary artery. So, ST segment depression in the posterior wall MI, you will have horizontal ST depression in the right precordial leads. We will also have tall and broad R waves, which are at least 30 milliseconds, again in the right precordial leads such as V1 and V3. You will have an upright T waves there. And you will have a dominant R wave in lead V2, which is defined as R to S ratio of more than 1. So again, take a look at this 12 EKG on the right side of the screen, where you see ST segment depression in lead V2 and V3. You also see very tall R wave in lead V2 and upright T waves as well. So such patients, especially if symptomatic and new finding, should be treated as STEMI, or ST segment elevation myocardial infarction. Let's briefly mention some other interesting patterns which can be seen in acute thrombosis of the main coronary artery. One pattern being de Vinters syndrome. It is present or presents itself with an upsloping ST segment depression in precordial leads such as V2 to V6. You will have tall T waves plus minus 4 RV progression. And take a look at this valid EKG where you have 4R wave progression and very tall T waves. Also, if you see that there is a ST segment depression in lead V3, V4, V5, and V6. And de Vinters syndrome is associated with left anterior descending artery occlusion. Let's talk about ST segment elevation now. It should be at least of 1 mm in two contiguous leads except in lead V2 and V3, where it's typically defined as at least 2 mm in men who are older than 40 years old, or more than 2.5 mm in males who are less than 40 years old. And it should be at least 1.5 mm in women. There are always, or almost always, reciprocal changes present. And what we mean by reciprocal changes: for example, you'll have ST segment depression in opposite leads. Let's say, for example, you have ST segment elevation in lead V1 and AVL, and reciprocal changes will present as ST segment depression in lead 2, 3, or AVF. Pay attention to this table on the right side of the screen. It shows you different vessels involved for different areas of MI or myocardial infarction, and typical EKG leads where these changes are present. Again, this is a testable topic, and please spend an extra second or two reviewing this table. Let's take a look and review how ST segment elevation MI or STEMI can present itself on a 12-lead EKG. Let's start with this EKG first. Here you can see upsloping ST segment elevation in lead 2, 3, or AVF, which are called inferior leads, and some reciprocal changes of ST segment depression in lead 1 and AVL. So this EKG represents an inferior wall myocardial infarction with a right coronary artery or RCA likely culprit lesion. Let's take a look at another one. On the second EKG, on the right, you see ST segment elevation in lead 1, lead AVL, lead V2 through V5. You also see some reciprocal changes in inferior leads, such as lead 3 and AVF. So the second EKG represents diffuse anterior wall myocardial infarction is a likely culprit lesion to be left anterior descending artery or LAD. Sometimes acute pericarditis can mimic acute myocardial infarction, both on the EKG and clinically, because quite often patients with acute pericarditis present with chest pain. Obviously, chest pain quality may be different, but this is beyond the scope of this lecture. In the acute setting, it is first important to rule out myocardial infarction before we start thinking more about pericarditis. So again, like I said, it can mimic ST segment elevation MI, and classically in pericarditis you have diffuse ST segment elevation with reciprocal ST segment depression in lead V1 and AVR. Let's talk about T-wave abnormalities. Normal duration of a T-wave is less than 0.25 seconds. Peak T-waves can be present in either coronary ischemia or in cases of hyperkalemia. T-wave invergence or negative T-wave can be a sign of ischemia, electrolyte abnormality, such as, for example, hypokalemia and hypomagnesemia, myocarditis, use of digoxin, and in certain patients who have subarachnoid hemorrhage or SIH. And here on this pictorial representation of EKG, you see some abnormalities. On the top right, you see what is called a T-wave inversion or negative T-wave. And on the second EKG on the bottom, you see peaked T-waves. Let's talk another pattern of acute coronary ischemia, which doesn't necessarily present with ST segment elevation. One being valence pattern. Valence pattern represents a critical left anterior descending artery disease. Again, like I mentioned, there is very little to no ST segment pressure or ST segment elevation, but you quite often see quite profound T-wave invergence. And again, you see T-wave invergence here in lead V2, V3, V4, and V5. And again, like I said before, always compare the new EKG to the old EKG to see whether these changes are new or not. Let's talk about the QT interval next. What is QTC, or corrected QT interval? QTC represents the QT interval divided by square root of the RR interval, measured in seconds. The QT interval duration is less accurate with extreme heart rate, such as extreme bradycardia or extreme tachycardia. In men, the normal QTC interval should be 440 or less milliseconds, and in women it should be less than 460 milliseconds. Let's briefly discuss prolonged QT interval. Prolonged QT interval is a risk factor for polymorphic ventricular tachycardia, also known as torsade de pointes. There are multiple reasons for that. Some of them acquired reasons, such as medications, and some of them are congenital. There are many medications which we use in anesthesia have the capacity to prolong QT interval, such as, for example, many antiemetics, certain pain medications, such as methadone. Also, electrolyte abnormalities, such as hypocalcemia, hypokalemia, hypomagnesemia, coronary ischemia, and bradyarrhythmias can all prolong QT interval. There are some congenital causes of prolonged QT interval as well, and these are beyond the scope of this lecture. So let's take a look at this 12-lead EKG. The EKG machine quite often will report you the QTC interval, but there is one quick way on how to eyeball it for yourself. So the normal QT interval should be roughly less than 50% of the RR interval. And again, if it seems that it's more than 50%, then it's likely to be prolonged, like in this case. Let's talk about short QT interval. Like the prolonged QT interval was not enough for us. It can be either congenital or acquired. Digoxin use, increased vagal tone, acidosis, hyperkalemia, hypercalcemia, coronary ischemia, and high temperature all associated with short QT interval, which is typically less than 360 milliseconds. And this short QT interval also predisposes to the risk of sudden cardiac death. Let's do a case. We have a 75-year-old female patient who presents to the hospital with left femoral neck fracture. She was taken to the OR on the hospital day number 2. The surgery was uneventful, and she's being born in the PACU. About 15 hours after the surgery, she started having shortness of breath, palpitations, and chest pain. We decided to obtain 12-lead EKG, which is shown here. Take a look and review this 12-lead EKG. So let's systematically review this 12-lead EKG. So the first question, what is the rhythm? And again, you see upright P waves in limb leads, so the rhythm is sinus. What about the axis? Again, take a look that the lead number 1, there is a deep S wave, and a positive QRS in lead 2. So the axis is going towards the right side, or right axis. Again, what about the heart rate? Roughly about 2 large boxes between the QRS complexes, so the heart rate is around 150. So this represents sinus tachycardia. The QRS itself appears to be narrow. The rate and rhythm appear to be regular. And there's also a poor R wave progression. Take a look at the precordial leads, especially lead P3. Another thing which is present on this 12 EKG is so-called S1 T3 Q3 pattern. If you pay attention, there's a deep negative S wave in lead 1, and there's a Q wave and negative or inverted T wave in lead 3. S1 Q3 T3 pattern, which is somewhat specific for acute pulmonary embolism. So what about 12 EKG in patients with acute PE? Most of the times you see sinus tachycardia. We already discussed S1 T3 Q3 pattern, new onset atrial fibrillation, new onset right bottom branch block, new onset right axis deviation, and non-specific ST segment changes. And again, let's refresh our memory about different EKG intervals. Let's take a look at this picture and see different waves and different intervals. So let's talk about basics of a paced EKG. You may have heard of different abbreviations for a pacer, such as, for example, VOO, DOO, and DDD. So what do they mean? So the first letter is typically the chamber which is being paced. For example, V for ventricles, A for atria, and D for bolus. Second letter is a chamber being sensed. Third letter is the pacemaker response to sensing. And the fourth letter is the rate adaptiveness of the pacemaker. For example, does the rate changes or gets adjusted for an activity. And again, here's a breakdown of different letters. In the end of this lecture, let's talk about basics of paced rhythm. Here you see two 12 EKGs of a patient who has a pacer. Let's take a look on the 12 EKG on the left part of the screen. You see there are two spikes. One is likely representation of atrial pacing, and the second one just before the QRS is a representation of a ventricular pacing. This is a paced, B-paced rhythm. Also take a look at the QRS morphology, especially in precordial leads, which resembles left bottom branch block pattern. On the right side of the screen, let's take a look at this EKG next. So on this EKG, you only see one spike, which occurs somewhat after the T wave, and then you follow it with a P wave. So this is a atrial paced ventricular sensed rhythm. The reason this is ventricular sensed because you see that the QRS is normal and there is no preceding spike before the QRS. Let's talk about some types of pacemaker malfunction which can be diagnosed with the help of 12 EKG. First, let's take a look at this EKG on the left side of the screen. We see that the QRS seems to be prolonged, the rhythm is irregular, and you see that there are some pacing spikes which are not followed immediately by either P waves or QRS complex. So this represents a loss of capture. Loss of capture can be either due to low battery, lead failure, fibrosis or inflammation on the lead tissue interface, or lead dislodgement. So let's take a look at another one on the right side of the screen. On the second EKG, you see that the pacing spikes occur irrespective of the QRS complex, which is a type of pacemaker malfunction called sensing failure. So the pacemaker itself can either undersense or oversense a native rhythm. In undersensing, the pacemaker doesn't see the native QRS complexes or P waves and doesn't recognize them. Understanding of a native rhythm can be considered as a risk factor for arrhythmias, such as RNT phenomenon. Oversensing can be a problem in patients with pacemaker who undergo surgery when cautery is used. So let's talk about the summary for the first lecture. On this table you see different EKG parameters, normal values, and clinical significance. Let's take a look and review this table. So here's the literature I used for this lecture. Again, the main goal of this lecture and the subsequent lecture is to help you become functional with rapid and dynamic EKG analysis, especially for acute and potentially life-threatening etiologies. I personally find this textbook called Marriott Practical ECG book very helpful. And again, I don't get any royalties or money from the publisher or the authors of this great book. Thank you again. I'll see you in the next lecture, and good luck.